suicide on the occasion of International Women's Day. I congratulate our Samanwi committee headed by Dr. C.H. Bharti Garu for planning this excellent topic and appropriate and much needed topic about the women suicides in women. And I also thank our speaker, Dr. Lakshmi Vijay Kumar Madam, for accepting our invitation to speak about this topic. And thank you very much, Madam. I also thank Dr. Radharani Garu for accepting our invitation to be the chief chairperson for today's webinar. Thank you, Madam. And I hope the CME will enrich our knowledge and also enrich our knowledge regarding suicides in women. I hope this will be a successful CME. Thank you.
Thank you, sir. Thank you so much for the brief introduction. Now I invite Dr. C.H. Bharati Garu, consultant psychiatrist Palakollu, and who is the chairperson of the Samanwi Committee, IPS AP State Bank, to introduce the topic and introduce the chairperson.
A very good evening to all of you, ladies and gentlemen, and a warm welcome to you. It's a privilege to be the chairperson of Samanwi Committee, for which I would like to thank the IPS AP chapter President Dr. Ivil Narasimha Rao Garu, Dr. GVS Murthy Garu, who is the Vice President, and the organizing secretary, Dr. Sharat Chandra, and you, Dr. Kishore. So, about the speaker, we all know what a big name Dr. Lakshmi Vijay Kumar is. Like, she's a authority on the prevention of suicides and suicides in particular. Despite all that, it was a big surprise because I've heard her on a number of platforms, and personally I didn't hear her at all. But still, when I called her and asked her to talk, she immediately obliged. She just did not bother about the size and nature of the platform. So thanks to Dr. Lakshmi Vijay Kumar for having accepted very graciously for today's evening Samanwi talk. And about the topic women and suicide, she was the one who suggested this topic. And why not? It's such a very, very pertinent, as Dr. GVS Murthy Garu has said, very important topic, because suicides in general are increasing at an alarming rate, especially women's suicide. And these days, again, more and more number. So the reasons and the intricacies of which I think, she would dwell upon. And about today's chairperson for this meeting, Dr. Radharani Garu, who is a very good friend of mine. She completed her MBBS in 1984 and did her DPM and DNB from IMH Hyderabad, after which she took over as a professor and superintendent of Government Mental Health Hospital, Vizag. And during her tenure, she was instrumental in bringing the Center of Excellence Award to that institute, thereby developing the institute. She has very number of publications, national and international. So I invite Dr. Radharani Garu to take over the proceedings.
Thank you, Dr. Bharat.
Radharani Garu cut out.
Good evening, madam. Is
Madam,
it okay now?
Now it's audible.
It's audible?
Now it's audible.
I'm sorry for my bad throat also. I'm having upper respiratory infection. I apologize for this. And it is my pleasure to chair a session of an eminent speaker like Lakshmi Vijay Kumar Garu on the very nice topic of women and suicide, where the suicide is very highest and it is drawing the global attention. And year by year, the global rate of the suicide is also increasing. Now, I would like to introduce Dr. Lakshmi Vijay Kumar Garu. She is the founder of Sneha, an NGO in Chennai for the prevention of suicide. And she is the head Department of Psychiatry, Voluntary Health Services, Adyar, Chennai. She is the member of WHO's International Network for Suicide Research and Prevention. She is an honorary associate professor in the University of Melbourne, Australia. And she was the vice president of International Association for Suicide Prevention for 4 years. She was awarded the Ringel Service Award by IASP She has been conferred honorary fellowship of the Royal College of Psychiatry, UK, for her work on suicide prevention. And she was the second Indian to receive this honor. She has also been conferred FRCP. She has been awarded the WPA honorary membership World Psychiatric Association. She was one of the editors of WHO report Preventing Suicide, a global imperative, published in 2014. She is in the editorial board of Lancet Psychiatry, Asian Journal of Psychiatry, and she has received numerous awards in India, such as for the sake of honor, Bharati Vindu Women Doctor of the Year, JLF Junior Fellow Women's Award, Excellence in Healthcare Award from the Hindu World of Women 2023, etc. She has actively worked for decriminalization of suicide, media guidelines for reporting of suicide. She played a major role in developing a national suicide prevention strategy for the India in November 2022. She has published over 100 papers in peer-reviewed journals and has authored several chapters. She is the reviewer of numerous journals and has edited 2 books. Her area of interest and expertise includes developing cost-effective community intervention to prevent suicide. Madam, with this short introduction, I request you to take over.
Thank you very much. Thank you very much for inviting me for this event, and it's a real pleasure and privilege to be here. And thank you for the kind introduction, and thank you for the invitation, Dr. Bharti, and thank you for the kind introduction. And I think I'll start. The tech support, can I share my slides? Is that okay?
Sure, ma'am.
Yeah. Is my slide visible for people?
Yes, ma'am.
Okay. Thank you very much. So I'll start with the suicide map of the world. Okay. And this suicide map of the world is, you can see that India, we have the dubious distinction of having a high suicide rate, which has been increasing. But what is more surprising is to look at this map, which is the male-female ratio of suicide around the world. And there you can see that the lighter colored countries are the countries which have a narrow male-female ratio. That is, more women die by suicide in these countries. Whereas if you look at the dark brown countries, for example, all the Eastern European countries and Russia and other countries, there are more than 5 times the number of men die by suicide when compared to women. For the ratio is almost 5:1. Whereas in our country, it's almost 1.4:1. That is more or less equal number of men and women die by suicide, which means that India has a large number of suicides by women. And so if you really look at the leading countries which has maximum suicide in the world, in the lower middle or in the middle income countries, India holds. And if you look at the numbers, you can see that we are the ones who contribute the maximum number of suicides, women suicides to the world. In this, we have even overtaken China. China used to be the one which has the largest number of suicides by women, around 43,000. But if you look at India, we are double that. So India is the one, India is responsible for almost 30% of suicides of women in the world, okay, which is a staggering, or like, let's say, very unsettling fact. So again, if you look at India, the number of deaths, India is ahead by more than double, okay? And if you look at the top 10 countries in terms of suicide rates, in the total suicide rates or in the male rates, India is not in the top 10. But when it comes to female suicide rates, India is in the top 10. And in the numbers, as I said, we are number 1 in this. Then if you really look at the prevalence of depression. We always say, okay, it is depression. This is why many people die by suicide. So this is the prevalence of depression, male versus female. And in all the 170 countries, if you look at the graph, there is not a single country where depression prevalence is higher in men than in women. Every single country in the world, the prevalence of depression is high in women. Okay. But if you look at the suicides, there is not a single country in the world where women have more suicides than men. So why this gender paradox? You have a high prevalence of depression in all the countries. All the countries have high prevalence of depression in women, but all the countries, the suicide rates are more in men. So why is this paradox? We call this as the gender paradox. So what is this paradox due to? Is it due to the method which people use? That men use more violent methods, whereas women use less violent method? Is it the question of help seeking? Men seek more help. Men don't seek help, whereas women seek help. Is it the religiosity which causes a thing? Or is it the comorbid alcohol and substance abuse which relates to more suicide in men? Of this, the only evidence exists for comorbid substance abuse. The men have more comorbid substance abuse, alcohol use disorder with depression than women. And 1/3 of our people die under the influence of alcohol. Okay. Now, if you look at the method, we cannot really say that women do not make serious, more violent methods. I mean, what can be more violent than self-immolation? It leaves the women scarred for life, both physically and figuratively and mentally. Okay. And you can see that about India, if you look at the number of self-immolation, this is the only method where women overscores men. This is the only method where women outnumber men. And almost 65% of self-immolations in India are done by women. Okay. And most of this is young married with marital conflict. The help seeking, this is a study which we did on people who have attempted suicide. We followed up about 600 people who have attempted suicide for over 1 year and tried to look at the differences between men and women. And definitely women seek help more openly for medical help, for from medical people, from health services, or from relatives, or even from others. This is a distinct difference between men and women. What about religiosity? Are men more religious? Are women more religious? If you really look at it, religion is not such a big protective factor for women. And actually, if you look at the graph, in recent times we have found that particularly in Muslim countries where the suicide rates are low, the women rates are high. So the religion of the Quran, which strictly forbids suicide, has some effect in reducing male suicide, but not in female suicide. So it is something which we need to do. And we know that there are many young brides in Afghanistan who self-immolate because they are married to much older, 30 years older men and all that. So this is a huge problem. So what about mental disorders and suicide risk? Okay. This is the background for, this is only for women. This is not for men. Okay. And what we are increasingly finding out is that apart from major depressive disorders, eating disorders and alcohol disorders have been increasing in women. And in young women, substance abuse, opioid dependence, marijuana dependence has also been increasing of late in the last 5-6 years. So, no, okay, we know that depression is very common in women, but the prevalence is so high. So how do we identify people who have attempted, who are likely to attempt suicide among the depressed women? Okay, we all come across women with depression, but not all women die by suicide or attempt suicide. So how do we identify? And this has been a very interesting article which looked at who are the people who are depressed. These are clinically identified and treated depressed women, and compared them with people who have attempted suicide and those who have not attempted suicide. And what is it that emerges most important? When you have decreased contact with family, that has the highest odds ratio as a risk factor. Apart from, and the next most important factor is suicide attempt. And when you have been alone as a child. So these are the important factors. And if you take the top three, it is decreased contact, aloneness, and previous suicide attempt. And what is emerging recently is the issue of physical appearance. Okay? Many young girls and adolescent girls are so unhappy with their physical appearance, particularly, and this is in relation to the number of hours they spend on social network also. Okay, and that has found to be this is a recent trend where we see an increase in attempted suicide in women. So we know that child sexual abuse is associated with depression and suicide. So what is the mechanism? Why is child sexual abuse at 6 years lead to a depression when you are adolescent and suicide attempt when you are an adolescent? The biggest problem is these children or young girls are not able to attach themselves to anybody. They cannot trust anybody. So there is an attachment avoidance. Okay. And there is an anxiety about attachment also. They are worried about getting close. Because they are not able to trust anybody, which leads to social maladjustment and suicidal ideation. So what are the cognitive domain regulation domains in the women which is associated with suicide? If we look at family and the group is group with suicide attempt, group without previous suicide attempt, healthy controls, and begs depression inventory. And if you look at that, in a family which is more accepting, there is a planning, positive reappraisal, the suicide rates are less. When there is more self-blame, when there is catastrophizing, small things appear too big for them. A fight with a friend is the end of life for them, that kind of thing. And other blaming everybody else except in themselves for all the problems they have. That has been found to be associated more with suicide, self-blame. Okay, acceptance is negatively, okay, and they keep ruminating about it. Okay, so, and then we also know that during a perinatal period, prenatal and postpartum, depression is high and suicide is high among women. So who are the women who are likely to have? Is it anybody who has postpartum depression? No. A lot of women have postpartum depression. But what has been found is those women who are undergoing postpartum depression, who are not able to sleep at all, insomnia, and nocturnal cognitive arousal. That is, in the night, all their negative thinking gets aroused. Those are the people who are likely to attempt suicide. Okay, and these are all remediable factors. If you are able to make sure that these women get at least 5-6 hours of quality sleep, so many suicides could be prevented. The other group is perinatal focused rumination. That is, how am I going to bring up the child? Will I be a good mother? Will my child be all right? Those people who are having those kind of ruminations are at a high risk. So insomnia is a very, very treatable condition in perinatal women. And that will rate, if you are able to handle that, either by medication or sleep hygiene or behavioral modification, 50% of the suicides occurring during the perinatal period can be reduced. And this is what message which I would like to convey. So this is done by a machine learning thing where they looked at people with major depressive episode, 7,700 people in control, and people who died by suicide in major episode, 1,000. And what was it that machine learning threw up? So this is done in Denmark, where you have all this fantastic data. But what is surprising is you can see that people who are getting, people who are not employed or who are not economically independent, they are given state, what is known as state pension. Okay. Those people who are on state pension, those women who are not economically independent and are getting the pension from the state, they are the ones who are at a high risk of suicide. And what is the next person? Those women who have been prescribed benzodiazepines for insomnia. Normally, this is what the GPs do. They prescribe benzodiazepine for women, particularly perinatal women or any depressed women with insomnia. And those are the women who, and benzodiazepine, increased use of benzodiazepine, long-term use of benzodiazepine have been associated with suicide, particularly in women. So another learning which we need to take is to educate the general practitioners not to prescribe benzodiazepine, particularly to perinatal women or elderly women who are living alone. So again, if you look at, I'm focusing more on our region, South Asian countries. If you look at countries like Bangladesh and even in India, you can see that for below 30 years, the suicide rate is more in women than in men. So in India, the highest suicide rate for any subgroup is women between 15 and 29. So it is not only a loss to the nation, but you're losing young mothers, you're losing young people in the family. So the another question which is asked is, marriage is supposed to be a very protective factor against suicide. Okay, it is true for men, but it is not true for women, particularly from Asian countries like India and China, and more so in the young people. Actually, being married at a young age has an increased risk. And if you look at our statistics, after the age of 30, the suicide rate in women in India comes down by almost 40%. Why is that? We have the highest suicide rate for women between 15 and 29, and then drastically drops down by 40% after the age of 30. It's mainly because by majority of the women in India by 30 have a child. And having a child is a protective factor. And so despite having difficult family situations or an alcoholic husband or whatever it is, the child acts as a protective factor. So marriage for a young till 30 is actually not a protective factor for women in our countries. Pregnancy-related suicide. We find that many pregnancy-related suicides are there. Okay, and this is, we lose mothers and children, and we also know about family suicides where mother literally murders the children and also dies by suicide. Which is a very heartbreaking occurrence in our country. I want to say it's not only in low and middle income countries this kind of problem exists. Even in the US, see, for example, if you really look at it, not all the states, that is, you have what is known as unilateral divorce laws. I mean, if the wife doesn't feel that she can live with her husband, she decides to say, yes, I want a divorce and you can walk. Okay, there is unilateral divorce laws. And different states introduced the unilateral divorce laws in the US. And this gave us an opportunity to study. And if you look at that top graph, you don't find any difference. The suicide rate doesn't make any difference at all at that age, because most of them are not married below the age of before 25. Okay, so the unilateral divorce laws didn't have any impact. And the same way, you go to the bottommost, above 65, you don't find any change at all. But if you look at 25 to 34, 35 to 44, 45 to 54, the state which produced unilateral divorce laws saw a significant reduction in suicide rates. That is, when women don't feel trapped in a marriage, the suicide rate comes down. Okay, this is that's supposed to be a developed country like the US. And there's another fallacy that the economic crisis which happens affects the men more than women. We now know it is not true. Actually, the women are the people who lose the jobs in economic crisis first. Even during COVID, when Japanese young women suicide rates are the ones which hit the high, because the first person to lose a job when there is an economic crisis or something disaster like COVID is a woman. And a person who is used to having an economic independence and suddenly it is taken away, okay, it diminishes her self-worth, it diminishes her self-esteem, and also the respect from others. And that produces suicide. So economic crisis actually affects suicide rate of women as much as it affects men. And of course, this is the elephant in the room. We all know that the association between intimate partner violence and suicidal ideation and suicide is extremely high. And the added catalyst for this is under the influence of alcohol. So it's a triad of alcohol use disorder, under the influence of alcohol, domestic violence, and suicidal ideation. It is a what shall I say? Partners in crime, I would say. So we know all about this, but there has not been a single intervention focused to reduce suicide in women. We have so many suicide prevention strategies, national strategies, and so on. But there have been only 2 or 3 intervention strategies focused only on women, which is a sad state of affairs. Okay. The only at a population level intervention strategy happened in Iran, where self-immolation of young women were high. So they took 2 districts, and in one district, they did a lot of psychological awareness. They had people with lived experience talk about it. They increased access to help. They increased awareness about the effect of self-immolation. And then you'll find that suicide attempt and suicidal ideation decreased in Glinga, which is the intervention village, whereas it did not happen in the control district. It's a district. Okay. So this is the only focused intervention focused on women. We did a small study in your state, I would say in Telangana, in Khammam district. Okay. Along with the Center for Sustainable Agriculture, we did a study on 4 villages where we actually identified, let's say, these are the 4 women who are widows of the farmers. We know there is a lot of farmer suicide in that area, and these women lost their husbands in their 30s and 40s. So they're all young widows between 25 to 40. Suddenly left with no husband, no idea of how to sustain, no idea of what to do with the children, with huge amount of role changes and responsibilities. So along with Center for Sustainable Agriculture, we devised a program of what is known as non-pesticide management of pesticides. Okay. So these villages where they introduced non-pesticide management of pesticide, which means they didn't use any pesticides at all. They used ginger garlic paste, female pheromones, and cow dung urine thing. Okay. And we compared it with chemical pesticide village, which are nearby. And you can see after the introduction of the non-pesticide management, the suicide rates in those villages came down just drastically. Not only that, these women formed a self-help group and bought a neem seed crushing machine. Their products were selling better because it was organic, and they didn't have to buy seeds from people at high rates. So they became economically independent. And so there are a lot of things which we can do. So what is it that we need to do to prevent suicide? One is education. Educating them to to understand, and then economic independence and opportunity to, what shall I say, opportunity to express their talents, okay, and support from the family. If we are able to ensure all that, then suicides can be prevented. And in India, we have a lot of women and children programs, maternal programs, and our children program. And in all those national programs, if the component of suicide prevention is embedded in it, so many suicides could be prevented, and we will not have that tag of having the highest number of female suicides in the world. Thank you.
Thanks so much, ma'am.
Yeah, if there are
For a
any
wonderful-
questions, I'm happy to answer them.
For a wonderful talk. We now know why you reached the place where you are because of so much of statistics, which is very, very important and pertinent. So one question from me, ma'am, like despite all the amenities at home, like in the past, for decades ago, there used to be, they never used to have all the amenities we had. It was pakka a male-dominated society, patriarchal system. Still, we did not hear so much of suicidal rate at that time. Not just it was not reported, women, it was unthinkable that people would go and commit suicide except in rare cases. Now, despite financial freedom, despite the career, wonderful education, and reaching great heights, and also nuclear families, not the joint families, where they may not have the harassments of anyone so called, but still, why is it that women are more fragile and less resilient, and why do they think of suicides at all despite all the freedom they are given?
Actually, if you really look at the statistics of India, from 1970 to now, the women's suicides have come down. In 1970, the ratio between men and women suicide was 1.1:1. Okay. Now, the ratio of men-women suicide in India is almost 1.82:1. So the women's suicides has come down drastically in the last 20 years. So it's not true that women suicide have increased in the last 2 years. Actually, if you look at the trajectory for the last 20-30 years, the women's suicides have come down. The ratio has become wider and wider. So if we reach 3:1, then it will be like a developed country. Okay. Now, in terms of why we are seeing more with more education, more economic independence. With more education and with more economic independence, there is also higher expectations from yourself and from others. Okay. And when you're not able to realize that higher expectation, suicides happen. Okay. The other major factor is about 30-40 years ago, majority of the women would be married by 21. So they would have had a child by 22-23. So there was there was more of a hold for them to do that. Okay. And before 30-40 years, we were in a joint family system, right? So there really was no privacy for you to go and do a suicide. There would always be somebody who would be there and they will prevent it. Okay. Here, as one of my professors used to say, before we used to have attached families and detached bathrooms. Now we have attached bathrooms and detached families. So, which has happened, and the family ties have broken down. Before we used to have, see, there may be many problems which we had. If those problems are something which you cannot share with your own siblings or with your own parents, but you will always have an uncle or an aunt or a cousin whom you are close to, and you will go and share it with them and they will do that. But now all those systems are weakened, and we are not used to seeking external emotional support. We have always been used to getting emotional support from our family. So when there is a problem within the family, we do not know where to go for help.
Thanks so much, ma'am. Kishore and Dr. Radharani, any questions? Can you just continue?
Madam, there is a question in the chat box, madam. Radharani madam, unnara madam? There is a question in the chat box. Suicide among health professionals, any data available regarding gender differences, madam?
Yes.
Suicide among health professionals.
Yeah. See, there is a startling fact that in the last 5 years, there have been more than 140 medical students who have died by suicide. Okay. And almost 60, 70 postgraduate students. And what is even more startling is about 1,200 postgraduate students have dropped out of college, have dropped out of their courses. Okay. If you look at the male-female gender, I think amongst medical students, we do not find a huge, it's almost the same. It's almost the same, men and women, slightly more men than women. It's like the general statistics, about 1.5:1. And majority of the reasons, actually, if you really look at it, is not only academic stress and all that, but interpersonal problems, marital issues, family pressures, all those kind of interpersonal issues.
Dr. Radharani is having a problem with her mic. Technical people, please add her. Any other questions, Kishore?
Madam, any differences between the specialties, madam? Actually, psychiatrists has more suicidal tendencies and suicidal.
Oh, the first group of people who are anesthesiologists.
Yeah.
Anesthesiologists have the highest number of suicides. And then actually in our country, it is obstetric and gynecologists. Okay. But if you look at it worldwide, psychiatrists have a higher suicides. Anesthesiologists, then second comes psychiatrists, if you look at it worldwide. But in our country, it is first is anesthesiologists, then obstetric and gynecology. In fact, there was a very interesting study done in Harvard about a few years ago. They tracked medical graduates when they entered medical school, for 6 years after they finished medical school, 10 years after they have chosen the profession, and 20 years after they are in the profession. So when all the medical students are taken in, there was not much of difference between the students. But when they chose specialities, two clear categories came about. One are the surgeons and the others are the psychiatrists. The surgeons were typically found to be, they did a personality assessment, everybody were more extroverted, more risk-taking behavior, more, what shall I say, more impulsive, okay? Whereas psychiatrists were more introverted, more withdrawn, more shy, that was the difference they were found. Then 15, 20 years later, they found that more psychiatrists died by suicide, but more majority of the surgeons were had alcohol use disorder. Okay. So the conclusion was that actually when you begin, see, it was always a question. whether people who chose psychiatry themselves were vulnerable and that's why they chose psychiatry, or whether the profession made them vulnerable. Okay. And now we have evidence to show that our profession makes us vulnerable to suicide. So it's very important for all of us to look after our mental health.
Well said, ma'am, because day in and day out, what we hear is only about anxieties, depressions, and all the negative things in a human being. So maybe that's one of the reason we become more vulnerable.
Yeah.
Dr.
So
Radharani?
it's
Yeah.
Yes, sir. Radhamani Chairman.
Ma'am, thank you very much for the very well presented lecture. We are all very happy to have you here in spite of your busy schedule, ma'am.
it's a pleasure.
And I apologize in between now due to technical reasons. I got disconnected from the thing. Finally, I'm added.
There is another
we
question
invite any
about
more-
gadgets.
Yes, ma'am.
I see in the chat
Yeah.
box there's another question about gadgets. Yes,
Yeah.
we have enough evidence to know that after 2 hours of internet, every hour of internet exposure is associated with suicidal behavior, and it is too different for boys. The more and more, if any boy spends more than 3 to 4, 3 or more than 3 hours on gaming, particularly violent gaming, they have more suicidal ideas. And for girl adolescents, if they spend more than 2 hours on social media, then definitely the suicidal ideas and attempts increase.
Ma'am, one question, madam. Good evening. Are there any differences for different psychiatric disorders like bipolar affective disorders, schizophrenia, or developmental disorders? Who are most vulnerable among all these disorders? Any specific statistics available, madam?
Yes, the most vulnerable is of course people with major depressive disorders. They are the ones who have the maximum number of suicides, followed by people with schizophrenia. Suicide among schizophrenia has actually come down. It used to be, we used to say that 15% of alcoholics, 15% of depressives, and 10% of schizophrenics end their life by suicide. Actually, in the last 10 years, particularly after the introduction of clozapine, suicide among schizophrenia has come down drastically. It is now only about 6% of schizophrenics end their life by suicide. And that too, we know when they will end. It is in early stages with early relapse and people who are high functioning. So those are the people who die by suicide. In terms of bipolar disorders, the people who have more and more mixed episodes are the ones who have high suicide rates, rather than there has been a lot of debate as to who has high suicide rates, bipolar people or people with unipolar depression or people with bipolar depression. The debate is still out there. We still don't know, but by and large, the research is trending towards unipolar depression having higher than bipolar depression. And alcohol, yes, definitely at least 15% of alcoholics end their life by suicide. Of late, we are seeing people with eating disorders, particularly in young people with anorexia, bulimic syndromes having high suicide rates. Funnily enough, children with the developmental disorders do not have a high suicide rate. They do not have a high suicide rate. People with obsessive compulsive disorder, I won't say it is very high, but it is not reaching the other places. But whereas people with panic disorders of late, we are seeing more suicidal attempts.
Good evening, Dr. Lakshmi. Prasad here.
Yes, Dr.
Thank
Prasad.
you, Akka. Thank you, Akka, for coming for us. I just have two questions. First question is, previously we used to talk about impulsivity as a variable. So among the various psychiatric disorder, did impulsivity continue to have about 10% of all suicide attempts and suicidal?
Among psychiatric disorders, one factor which cuts across all psychiatric factors and is related to suicide is hopelessness. Hopelessness is, if anybody is schizophrenia, depression, or bipolar, or panic, if they score high on hopelessness, those are the people who have a high risk of suicide. Impulsivity is definitely there, particularly among young people. But in older people, it is hopelessness. Impulsivity is hallmark of an adolescent suicide.
Yes, yes. The second question is coming to the adolescents. Do you think that there is an increasing trend in the last 2 decades in our Indian studies on adolescents?
Yes. Adolescent suicides, if you really look at it, the two countries which have shown an increase in adolescent suicide is India and the USA.
Yeah.
These are the two countries which have really shown an increase in adolescent suicides. And that is a real cause for worry. Already we are losing a lot of people to young people to suicides. As I said earlier, between 15 and 29, suicide is the first cause of death for a young girl. It's not maternal mortality or any other infection.
And among the child and adolescent, any clinical diagnosis? Because I think we have a very quite complex things when we diagnose child and adolescent. So
in children and adolescents, it's very difficult because diagnostic formulation itself is very difficult with adolescents. And we do not know, and the psychological symptoms keep changing, varying. So in adolescence, very quickly we may change from a mood disorder to a thought disorder and so on. So it's very difficult to come to a diagnosis for an adolescent behavior, for an adolescent suicide. In fact, we are not looking now at diagnostic entities as in DSM or ICD-11 because many adolescents don't come under those things. So we are looking at what traits these adolescents have, which push them. And some of the traits which push the which are associated with suicide, which is developing of late, is what is known as decision-making difficulties. These adolescents have difficulty in making decisions. They always choose the wrong decision and they will never learn from it. Okay? So decision-making difficulties they have. The other major difficulty they have is in regulating their emotions. They cannot control their emotions. They will just act out their emotions, either sadness or happiness or anything like that. That's another personality characteristic we have found. And the third important personality characteristic we found is that they have what is known as poor specific memory. They have generic memory, but do not have, they have memory deficits. They have poor specific memory. There are very good examples for why this specific memory is lost, particularly with girl children with sexual abuse. So those kind of multi-dimensional research is going on. So these are the kind of characteristics which we find. And all of them uniformly have poor interpersonal skills.
thank you. Thank you very much. I think I learned a few more points from you as usual.
Yeah, my pleasure. Thank you for joining in spite of your busy schedule.
No.
All of you.
Thank you.
Ma'am, can I ask you just one thing? Like in India, you said, above 72,000 people are deaths we see by suicide. But again, it's related to the population also, don't you think, when compared to rest of the world?
Yes, I'm not saying no. But then China has equal number of population.
Very true.
China had the highest number about 10 years ago, but they reduced the female population suicides. We have not.
The other thing is about the 9th, 10th class people also.
What about, there is another thing. What about adolescents who smoke marijuana? What is the idea with them? Yes. In fact, there is a very nice study which has just been, I just reviewed it. Everybody is legalizing marijuana now, okay, and saying it is of no consequences and all that. But we have enough. There are two things which we need to do. There has been a study which has been done in the US, which looked at different states again introduced laws, one for medical marijuana use and another for recreational marijuana use, liberalized. Okay, and there we find that those states which had liberalized recreational marijuana use, the suicide rates in adolescents between 18 and 23 had gone up. So it has gone up statistically. The other thing which is also found out is, particularly if the child had smoked marijuana by 14 or 15, they are the ones who are at a high risk of suicide. So this has been done. And, apart from that being an entry point for other drugs and so on and so forth, even if you have stuck only to marijuana, if you have smoked it a bit at 14 and 15, then your chances of developing psychological problems and suicide is high. Not so much after 18. So that 14, 15 seems to be brain cognitive development, it seems to affect. And as I said, the reason this is a paper which I've just reviewed for JAMA Psychiatry, which would be printed shortly. Those states which had used, which had allowed recreational marijuana use had higher adolescent suicides.
Hello, madam. I'm Dr. Rekha Dutt. In fact, this is my question that you just answered. And it's very important that, very interesting that you said that point that 40 people who started at the age of 14 are having more suicidal rate, because some studies have shown that the cytoarchitecture of the brain, the neurons changes because of marijuana, even if it is just weekend use. I think that could have led to a possibility of more clinical depression in these students, the adolescents.
Yeah.
Thank you for that answer.
Thank you. I'm really sorry. I have another meeting with NIMH and WHO, so I have to jump into that. But thank you for this opportunity. Thank you for your interest. Thank you for your patience, and thank you for your questions.
Thank you so much.
Thank you, madam. Thank you.
Thank you very much, ma'am.
Thank you. Ma'am, thank you so
Sorry,
much.
I
ma'am.
have to leave. If you have any more questions, just email to me and I can answer them.
Thank you.
Sure. Sure.
Thank you.
Sorry to leave
Thank-
now.
No.
Thank you.
Thank you.
Thank you.
Dr. Kishore, just ask Dr. Radharani to join. No, it's between the.
మేడం రాధారాణి మేడం ఆల్రెడీ ఉన్నారు మేడం, మనకి కనిపిస్తున్నారు. మేడం కనిపిస్తుంది మ్యూట్ లో ఉన్నారు
Oh,
మేడం. ఎన్ని ఫైనల్ వర్డ్స్ మేడం?
Dr. Radharani.
Yeah.
No,
I'm online only.
yeah, please. She just left.
Yeah. I think there are no further questions.
Madam, there is a question, madam.
So-
Just there is a question from my side, madam. Actually, I just posted now.
Yeah.
Is there any which is the stressor which are the least temporal association, so that we can have be so cautious? Just I want to any senior psychiatrist can.
No, I didn't get your question. What did you say?
So which are the least temporal association? Which stressor has the least temporal association with the attempt or a completed suicide?
No, we can say the top 5, which is losing a spouse, losing a son, a severe financial things, and definitely interpersonal relations. These are the top 5. But least means, see, we have about in the list of say Gurmeet Singh's PSLES or anyone, restaurant would automatically come on the lower side. Least, I'm not very sure the last point among the list of the people. But I think the top 5 we know very well, and it is so consistent. And nowadays, what is changing probably is the adolescents and the cannabis have been added to the things. But otherwise, stressful things in the adolescents, the relationship and the drug abuse, early drug abuse has been associated now.
So these days, I have seen an young teenager who has watched the dark gore website where there will be very violent killing people, violent videos. Immediately after seeing those videos, these people are getting suicidal thoughts. And they are attempting suicide. So I think we remember in that our last 2 years back, I think there is a online game going on, a Blue Whale game. The challenges are given to the students or the people who are participating in that game. they should kill themselves. So these are the just I want to add. డార్క్ గోర్ వెబ్సైట్స్ ఈ మధ్యన ఎక్కువ చూస్తున్నాను సార్. ఈ మధ్యన in the last few days I have seen two cases of young teenagers who have seen those dark websites and they're getting a very suicidal thought.
Maybe in the recent times, the COVID should be also be added to the stressors. COVID infection in the family, COVID for the patient. They both have been added in the larger international literature. Anyway, thank you, Radharani Madam and everyone for making me join the meeting, and I thoroughly enjoyed the Samanwi group.
You can just
Thank you very much,
wait
sir.
for a
Thank
minute.
you.
I think all
Thank
the
you, sir.
questions
Thank
are
you.
over to you, Jayapia. Dr. Radharani garu.
I think there are no other questions. I thank the organizers for giving me the opportunity. And because of some technical reasons, I could not attend in between immediately after Madam's talk. So I apologize for that. And thank you very much. And I hand over to Dr. Kishore for conclusions,
Yes, ma'am.
concluding the session.
Thank you, madam.
Thank you.
So, madam, thank you so much, madam. I thank today's speaker, Dr. Lakshmi Vijay Kumar garu, who has really enlightened us about this topic. I thank Dr. Radharani garu, who has chaired this session, and you being in this chairing person was very attractive to our session, madam. And I thank Dr. Bharati Chella garu, who is the chairperson of the Samanwi committee, who is leading this committee with a very wonderful session. We thank you, everyone. We thank all the, we thank to Murthy sir for giving initial remarks, and all the senior psychiatrists, Prasad Rao sir, Jeevaram Rao sir, all the people, even Rashekar sir, I think Rashekar sir is also online, joined, all the senior psychiatrists who have joined the Samanwi committee today, Samanwi committee's CME. Thank you so much. All the delegates. Not but not the least, I thank the Sun Pharma who has sponsored, who has been helpful, who has sponsored this session by providing the online meeting. Thank you everyone.
Dr. Kishore, thank you, Dr. Radharani, thank you, GS Murthy garu, Raman Rao garu, everyone.
Thank you.
Thank you, madam.